Treat the sick child or the sick young infant. Overview of the types of treatment. The IMCI chart titled Treat the Child shows how to do the treatment steps identified on the Assess and Classify chart. So treat means giving treatment in clinic, prescribing drugs or other treatments to be given at home, and also teaching the child's mother or caretaker how to carry out the treatments. So here's are the charts describes on how to carry out the treatments. So first we have here give oral drugs. Next is treat local infections. Next is give intramuscular drugs. Next is treat the child to prevent low blood sugar. Next is give extra fluid for diarrhea and continue feedings. And lastly, give follow-up care. Similar instructions are included in the Treat the Young Infant and Console the Mother section of the Assess, Classify, and Treat the Sick Young Infant chart. Instructions are all appropriate for young infants and should be used instead of those on the Treat the Child chart. For example, the antibiotics and dosage on the young infant chart are appropriate for young infants. Exceptions are the fluid plans A, B, and C for treating diarrhea and the instruction for preventing low blood sugar. So, in this case, the Treat the Child chart is used for young infants as well as older infants and young children. So, the oral drugs, intramuscular drugs, and other treatments presented in the chart are recommended for first-level health facilities in your country. Both first and second line oral antibiotics and anti-malarials are included. First-line drugs were chosen because they are effective, easy to give, and inexpensive. You should give a second-line drug only if a first-line drug is not available, or if the child's illness does not respond to the first-line drugs. So we have here treatment in clinic also involves. So first, teaching the child's mother or caretaker to give oral drugs and or treat local infections at home, and consoling the mother or caretaker about feeding, fluids, and when to return to the health facility.
Urgent referral is sending a patient immediately for further care at the hospital. A child presenting any general danger signs like unable to drink or breastfeed, vomits everything, convulsions, and is lethargic and unconscious is likely to have a very severe disease. In this case, the child needs an urgent attention and care, hence urgent referral is needed. Community health centers are capable of treating mild cases of diseases and not so with severe cases because they lack resources in doing so. Severe cases are considered emergencies in this level of health facility. In that sense, they do urgent referral for the child to receive the best and quality treatment from a higher hospital equipped with essentials for the best management. But before they refer the child, of course, they first assess the child and do specific pre-referral treatments. There are 3 urgent pre-referral treatments given to the child. First is intramuscular antibiotic if the child cannot take an oral antibiotic, quinine for severe malaria, and breast milk or sugar water to prevent low blood sugar. These pre-referral treatments gave the first line of care and action in treating the child and prevents a worst-case scenario from happening, hence preserving life during the referral process. Before jumping in explaining each pre-referral treatments, we should first know the steps for giving urgent pre-referral treatments. The first on the list is explain to the mother why the drug is given. As a guardian, it is her right to know what drug is being given to her child and its effects, and as a nurse, it is one of her roles to educate the mother properly and do health teaching appropriately to avoid anxiety and prevent misunderstandings from happening. Next is determine the dose appropriate for the child's weight or age. Yes, of course, because the child's weight and age affects how long the drug stays in the body and its effects. Use a sterile needle and sterile syringe when giving an injection. This prevents the spread of possible infection to the child and to the caregiver. Measure the dose accurately. Bawal ang malagpas, bawal sad ang magkulang to prevent you from bringing harm to the patient. Give the drug as an intramuscular injection. Intramuscular injection is ideal in these kind of situations because of its prolonged action yet fast absorption rate. Then if child cannot be referred, follow the instructions provided. These instructions can be found in the booklet and in the handbook. Let's move on to the first pre-referral treatment, the intramuscular antibiotics for the sick young infant ages 1 week up to 2 months. Young infants get 2 intramuscular antibiotics, intramuscular gentamicin and intramuscular benzylpenicillin or ampicillin. Young infants are prone and vulnerable to broader range of bacteria. That's why the combination of gentamicin and penicillin is given because it is effective against this broader range of bacteria. The table below shows the dose and schedule of the 2 antibiotics basing from the infant's weight. As you may notice, ampicillin is the one depicted in the table and not benzylpenicillin. Actually, these 2 drugs are both members of aminopenicillin family, so they are somehow the same. It is important to note that if referral is not possible, continue to give ampicillin and gentamicin for at least 5 days. Give ampicillin 2 times daily to infants less than 1 week of age and 3 times daily to infants 1 week or older. Give gentamicin once daily. Then we have here intramuscular antibiotics for the sick child ages 2 months up to 5 years. Many severe cases need the first dose of antibiotic before referral. However, if a child is not able to drink or breastfeed, or vomits everything, or has convulsions, or is lethargic or unconscious, the child cannot take an oral antibiotic. Instead, give this child a single dose of chloramphenicol or another intramuscular antibiotic recommended by the national program. Here is the schedule and dose table for intramuscular chloramphenicol. There are specific doses given the age or weight of the child. If referral is not possible, repeat the chloramphenicol injection every 12 hours for 5 days. Then change to an appropriate oral antibiotic to complete 10 days of treatment. This table is showing the dose and schedule of the 2 antibiotics to the children aging 2 months to 5 years old. This first pre-referral treatment is applicable for very severe disease like severe pneumonia, very severe febrile disease, severe complicated measles, mastitis, and complicated severe acute malnutrition. Then we have the second pre-referral treatment, the quinine for severe malaria. A child with very severe febrile disease accompanied with high fever may have severe malaria. Giving a quinine injection before referral kills malaria parasites as quickly as possible. Intramuscular quinine is also safer than intramuscular chloroquine. Chloroquine is another drug used for severe malaria. Use the child's weight if the child can be weighed when choosing the right dose. The drug also has possible side effects like sudden drop in blood pressure, dizziness, ringing of the ears, and a sterile abscess. If a child's blood pressure drops suddenly, the effect stops after 15 to 20 minutes. The dizziness, ringing of the ears, and abscess are of a minor importance in the treatment of a very severe disease. The dose and schedule of the drug is given here in this table, and as you can see, there is another drug present called artesunate. The dose and schedule of this drug is also given in the table. Here in the country, both of these drugs are used for severe malaria. Last is to prevent low blood sugar. Preventing low blood sugar is an urgent pre-referral treatment for children with very severe febrile disease. Low blood sugar occurs in serious infections such as severe malaria or meningitis. It also occurs when a child has not been able to eat for many hours and is dangerous because it can cause brain damage. Giving some breast milk substitute or sugar water provides some glucose to treat and prevent low blood sugar. This treatment is given once before the child is referred to the hospital. If the child cannot swallow and you know how to use a nasogastric tube, give him 50 ml of milk. It can be an expressed breast milk or breast milk substitute or sugar water by NG tube. But if the child is able to breastfeed, ask the mother to breastfeed the child. While to make sugar water, just dissolve 4 level teaspoons of sugar in a 200 ml cup of clean water. This treatment is applicable for patients with very severe febrile disease and complicated severe acute malnutrition and as well as severe jaundice. Here are the procedures for giving intramuscular injections. First, determine the dose according to the dose and schedule tables. Make sure you read the chart correctly for the concentration you are using. Then mix carefully and shake the vial until the mixture is clear. For quinine, no mixing is needed. Use a sterile needle and sterile syringe. Measure the dose accurately. For quinine injections, use a syringe with fine graduations such as tuberculin syringe. This type of syringe is used for this drug because this drug comes with very small doses or small amounts. Make sure the child is lying down. This is the safest position for the presentation of possible side effects, like the quinine, which may cause a sudden drop in blood pressure. Give the drug as a deep intramuscular injection in the front of the child's thigh, not in the buttock, because we are trying to not hit the sciatic nerve found in that part, which can lead to an injury of that nerve. Never give quinine as a rapid intravenous injection. This is extremely dangerous because of its very rapid action. Lastly, refer the child urgently, following the referral steps below, which I will be explaining later, keeping the child lying down. An example of tuberculin syringe is being depicted in the left image, while the syringe used for chloramphenicol is being depicted on the right. Now we are down to the referral process. Do the following 4 steps to refer an infant or child to hospital. First, explain to the mother the need for referral and get her agreement to take the child. This is a must to ask permission to the mother since she is the guardian of the child, and encourage her for the referral because this is clearly in need. If you suspect that she does not want to take the child, find out why. There are possible reasons, like she thinks that hospitals are places where people often die and she fears that her child will die there too. She does not think that the hospital will help the child. She cannot leave home and tend to her child during a hospital stay because there is no one to take care of her other children, or she is needed for farming, or she may lose a job. She does not have money to pay for transportation, hospital bills, medicines, or food for herself during the hospital stay. So these are just common reasons why guardians don't want their child to be referred to a hospital. As the anxiety and fears are showing off because of those reasons, as a nurse, you need to calm the mother's fears and help her resolve any problems. For example, if the mother fears that her child will die at the hospital, we assure her that the hospital is a place for treatment that has physicians, supplies, and equipment that can help cure her child. Explain what will happen at the hospital and how that will help her child. So explaining the effects and the advantages of the referral to the situation of her child can help. If the mother needs help at home while she is at the hospital, ask questions and make suggestions about who could help. It can be any family members. For example, ask whether her husband, sister, or mother could help with the other children or with meals while she is away. Discuss with the mother how she can travel to the hospital. Help arrange transportation if necessary. Yes, nurses can do that too. You may not be able to help the mother solve her problems and be sure that she goes to the hospital. However, it is important to do everything you can to help because it is one of the important responsibilities of a nurse. Now, if the mother or the guardian of the child granted the permission for a referral, the nurse now will write a referral note for the mother to take with her to the hospital and tell her to give it to the health worker there. The referral note should be composed of the name and the age of the infant or child, the date and time of referral, description of the child's problems, the reason for referral, including the symptoms and signs leading to severe classification, the treatment that you have given, and any other information that the hospital needs to know in order to care for the child, such as earlier treatment of the illness or immunizations needed. Then your name and the name of your clinic. All of these are vital components of that hospital to come up with the best management for the child's health situation. The last step is to give the mother any supplies and instructions needed to care for her child on the way to the hospital. If the hospital is far, give the mother additional doses of antibiotic and tell her when to give them during the trip. If you think the mother will not actually go to the hospital, give her the full course of antibiotics and teach her how to give them. Proper health teaching is needed here to ensure appropriate administration of the medication. Tell the mother how to keep the young child warm during the trip. Tell her that she can provide skin to skin contact or keep the young infant clothed or covered as much as possible all the time. Or she can dress the young infant with extra clothing, including hat, gloves, socks, and wrap the infant in a soft, dry cloth and cover with a blanket. Advise the mother to continue breastfeeding. If the child has some or severe dehydration and can drink, give the mother some ORS solution for the child to sip frequently on the way. ORS or oral rehydration salts is a mixture of glucose and salts given to the patient with dehydration. And here is the example of a referral note. This is from the DOH website. So that is all for the urgent referral topic.
So, hey guys, now we're going to proceed to the appropriate oral drugs. So, sick children often begin treatment at a clinic and need to continue treatment at home. The treat the child chart and the treat the young infant and conceal the mother section of the young infant chart describe how to give the treatments needed. Use this chart to select the appropriate drug and to determine the dose and schedule. So, the success of the home treatment depends on how well you communicate with the child's mother or caretaker. She needs to know how to give that treatment. She also needs to understand the importance of the treatment. There are some important points to remember about each oral drugs. So, the success of a home treatment depends on how well you communicate with the child's mother or caretaker. So, ang buti pa sa botani niya is ang success of home treatment doesn't only came from you as a nurse and to the mother as a mother, kung dili from the both of you guys. So, balik, kinahanglan maintindihan sa nanay or sa mother ang imong bot ipasabot or ang imong or yung gusto mong ipahiwatig at ituro sa kanya para yung yung treatment is maging successful sa bahay. You cannot only say na, sige ma'am, paulion na nakong imong anak niya, adi ang mga medisina, ipatumar lang ni niya, ipatumar lang ni sa iya. Dili man na pwede. You cannot do that. Kung dili, you need to teach the mother the correct by step of the treatment or step by step treatment ang imong kinahanglan i-educate dito sa mother. Then kita pod if na or gain feedback or wait for a feedback para masabtan nimo if nakaintindi na ang mother sa imong buti pasabot para ang success sa treatment is maging successful. So, mauto siya. Now, we're going to proceed for the oral antibiotics, which is the classification na. So, the following classification need an oral antibiotic. So, for sick young infant age 1 week to 2 months, mauni ang iyang classification na need niya og oral antibiotic. So, if naa siya'y local bacteria infection, yan dysentery. And for sick children age 2 months up to 5 years, kani siya is ang bata is dako-dako na ni siya is ang iyang classification na nga need niya og oral antibiotic is severe pneumonia or very severe disease, pneumonia, severe dehydration with cholera in the area, dysentery, very severe febrile disease, severe complicated measles, and mastoiditis, and acute ear infection. In many health facilities, more than one type of antibiotic will be available. So, sa mga health facilities na ay daghan na klasig antibiotics. So, you must learn to select the most appropriate antibiotic for the child's illness. If the child is able to drink, give an oral antibiotic, give the first line oral antibiotic if it is available. So, if ang bata makainom na siya og oral antibiotic, pwede mo na siya hatagan og oral antibiotic kay makainom naman siya. Alangan naman ihatag nimo ang oral antibiotic sa dili makalunok og tabletas na bata, di ba? So, if naapod first line oral antibiotic, mao ang inyong ihatag didto sa bata. So, the first line antibiotic has been chosen because it is effective, easy to give, and inexpensive. Recommended first line and second line antibiotics may need to be changed based on resistance data. So if nakikita nimo na ang infection is dili siya matambal sa oral antibiotic na imong gihatag, so need nimo na siya balyuan. Okay? So you should give the second line antibiotic only if the first line antibiotic is not available or if the child's illness does not respond to the first line antibiotic. Some children have more than one illness that requires antibiotic treatment. Whenever possible, select one antibiotic that can treat all of the child's illness. So, bale, ang imong ihatag na oral antibiotic, if possible, is ang makatreat siya sa tanan nga sakit sa usa ka bata. Okay? If possible. Then, sometimes one antibiotic can be given to treat the illnesses. Like, for example, a child with pneumonia and acute ear infection can be treated with a single antibiotic. A child with dysentery and acute ear infection can be treated with cotrimoxazole. If the first-line antibiotic for an acute ear infection, cotrimoxazole is also a first or second-line antibiotic for dysentery. Mauni siya ang giingon na if possible, pag select one antibiotic that can treat all of the child's illnesses. Then naapod tay sometimes more than one antibiotic must be given to treat the illness or illnesses. For example, the antibiotic used to treat pneumonia may not be effective against dysentery in your area. In this situation, a child who needs treatment for dysentery and pneumonia must be treated with two antibiotics. The treat chart shows the schedule for giving the antibiotic and the treat chart shows the schedule for giving the antibiotic and the correct dose of the antibiotic to give to the young infant or child. The schedule tells how many days and how many times each day to give the antibiotic. Most antibiotics should be given for 5 days, and the only cholera cases receive antibiotics for 3 days. The number of times to give the antibiotic each day varies 2, 3, or 4 times per day to determine the correct dose of the antibiotic. Then refer to the column that lists the concentration of tablets or syrup available in your clinic. Choose the row for the child's weight or age The weight is better than the age when choosing the correct dose. The correct dose is listed at the intersection of the column and row. So, magva-vary ka mo sa inyong clinic or magva-vary ka mo sa antibiotic na inyong ihatag sa list of so, ngadto sa list of concentration na naa sa inyong clinic na available sa inyong clinic before ka mo maghatag og dose ngadto sa bata. So now we're going to proceed to the example chart. So now, give an appropriate oral antibiotic for pneumonia, acute ear infection, or very severe disease. So the first line antibiotic is the cotrimoxazole, and the second line antibiotic is the amoxicillin. So kaning top is the schedule for cotrimoxazole, kaning give 2 times daily for 5 days. Then ang kaning usa is for the syrup na siya, dose of syrup for a child age 2 months up to 12 months. Okay, ay, sige. Anto na kita, mag-proceed na kita ha. So, nga dita sa pediatric tablet. So, ang cotrimoxazole is a combination of 2 milligrams trimethoprim and plus 100 milligram sulfamethoxazole. Sulfamethoxazole. Okay, so dito sa age or weight niya, mag-vary. So, ang bata is 12 months up to 2 months up to 12 months. So, naa siya timbang na 4 or less than 10 kilograms. So, ang imong ihatag na tablet is duha. So, you're going to give 2 tablets given 2 times daily for 5 days. But remember na ang imong tatagaan lang og 5 days is ang mga bata na walay cholera, since cholera cases receive antibiotics for only 3 days. Okay? Then also note that avoid giving cotrimoxazole to a young infant less than 1 month of age who is premature or jaundiced. Give this infant amoxicillin or benzolpenicillin instead. So, dili ka makahatag og cotrimoxazole sa bata na 1 month of age na may da or premature or jaundice. Ang imong ihahatag sa iya is amoxicillin or benzolpenicillin. Okay? Kana. So ang next ani niya is if dili available ang pediatric tablet, if available ang adult tablet, then you're going to check the chart again, then look to it kung ilan ilang tabletas ang iyong ipapainom sa bata. For example, dito, ang naka-indicate dito is 2 months up to 12 months, 4, tas ang iyong weight is 4 or less than 10 kilograms, ang imong ihahatag na tabletas is 1/2 tablet given 2 times daily for 5 days. Okay, then if ang bata dili pod makainom og tabletas, tagaay siyag syrup which is indicated gihapon, ang iyang age kung maulag gihapon, ang imong ihatag is 5 ml. Okay?
Okay, so going to oral antimalarials. Oral antimalarials vary by country. Chloroquine and sulfadoxine pyrimethamine are the first line and second line drugs used in many countries. The first and second line oral antimalarials recommended in your country are on the treat chart. It may be that only the first line antimalarial is available at your clinic. So in the IMCI booklet, we could see there that treat the child chart that is used to determine the dose and schedule for an oral antimalarial. So there are a few important points to remember about giving oral antimalarials. So first, treatment with chloroquine assumes that the child has not already been treated with chloroquine. So as I've said earlier, chloroquine along with sulfadoxine pyrimethamine are the first line and second line drugs used in many countries. This is for treating and preventing malaria, which is a serious and sometimes fatal disease caused by a parasite, commonly mosquitoes, which feeds on humans, and they exhibit high fevers, shaking or chills, and flu-like illnesses. So before administering this drug to the patient, you have to confirm this with the mother because chloroquine is dangerous in overdose and has been used extensively for suicide. And high concentrations of this drug of chloroquine can cause hypotension, acute respiratory distress syndrome or ARDS, fatal cardiac arrest, coma, and arrhythmias. However, chloroquine poisoning also depends on the dose ingested. Ask her if her child has already been given a full course of chloroquine for this fever. If so, and the child still has fever, consider this a follow-up visit. Use the instructions in the box. Give follow-up care malaria on the Treat the Child chart. So we have here the follow-up care malaria chart, and it is indicated that if fever persists after 3 days, the nurse should do a full reassessment of the child, and you have to see the assess and classify chart. So for reference, this is the assess and classify chart. So going back, for the nurse should not repeat the rapid diagnostic test if it was positive on the initial visit. So for the treatment, if the child has any general danger sign or stiff neck, the assessment would be treated as very severe febrile disease, which is also known as a severe malaria. So if the patient has stiff neck, general danger na siya kasi it may be accompanied with meningitis and sepsis, which is a life-threatening medical emergency na siya. So for second, if the child has no other cause of fever other than malaria, the nurse should provide appropriate treatment. And there are 3 indications under the no other apparent cause of fever treatment for malaria. First is that if fever has been present for 7 days, the patient would be referred for assessment. Second, do a microscopy to look for malaria parasites. If parasites are present and the child has finished a full course of the first-line anti-malaria, give the second-line anti-malarial if available, or refer the child to a hospital. So in the Philippines, ang first-line medicine in the treatment of confirmed, uncomplicated, and severe Plasmodium falciparum malaria is the combination of artemether lumefantrine, which would replace the chloroquine and sulfadoxine pyrimethamine combination. If ang AL or ang artemether lumefantrine kanang dili siya available, whether the patient is conscious or unconscious, tapos in case mag-aadag failure sa treatment, ang quinine combination with either tetracycline or doxycycline or clindamycin will be the second line treatment diri sa ato sa Philippines. So lastly, if there is no other apparent cause of fever and you do not have a microscopy to check for parasites, ang child is ma-refer na siya sa hospital. So again, for reference, mo ni siya ang itsura sa assess and classify chart. Siya ang management of the sick child aged 2 months up to 5 years. So second important point to remember about giving oral antimalarials, chloroquine is given for 3 days. The dose is reduced on the 3rd day unless the child weighs less than 10 kilograms and you're giving the 150 milligrams base chloroquine tablets. So in this case, the child is given the same dose, that is 1/2 tablet on all 3 days. So kato nga na siya. Chloroquine is sold under the brand name Aralen, and it is sold as a generic medicine. Kanang we have to keep in mind that chloroquine is available in 2 sizes, in tablets of 2 sizes. So ang first is ang 150 milligrams base tablet, or also known as the 250 milligrams salt. Tapos ang ikaduha, which is ang 300 milligrams base tablet, or also known as the 500 milligrams salt. Kanang we should know that this 150 milligrams base tablet is the same as 250 milligrams salt tablet, pati na po ang 300 milligrams base tablet is the same ra po ni siya sa 500 salt tablet. Kanang it's just 2 different ways of describing the same thing, which is according to CDC ni siya. So likewise, correct weekly dose for your child is based on the child's weight and should not exceed the adult dose, which is the 300 milligrams base tablet na siya. So, third important point to remember when giving an oral antimalarial is that cotrimoxazole may be used both as antibiotic and as antimalarial. It is effective against P. falciparum malaria in children under 5 years of age if given for 5 days. So, P. falciparum malaria also known as Plasmodium falciparum, is a species of parasite that causes malaria in humans. It is transmitted through the bites of female Anopheles mosquitoes. So, note that amoxicillin and chloramphenicol do not work against malaria kasi they are both antibiotics. So, they found that antibiotics in the blood of malaria-infected people is at risk of increasing disease transmission kasi the antibiotics in the ingested blood enhances the susceptibility of Anopheles gambiae mosquitoes to malaria infection by disturbing their gut microbiota. So, in many countries, cotrimoxazole works because, like sulfadoxine pyrimethamine, it is a combination of two antifolate drugs, which is a type of drug that stops cells from using folic acid to make DNA and may also kill cancer cells. This drug is effective against the falciparum malaria parasite in its most severe form. So the last point to remember when giving an oral antimalarial is that you have to explain to the mother that itching is a possible side effect of chloroquine. It's not dangerous, though it could be if kana siyang sa overdosing. So the mother should continue giving the drug. The child does not need to return to the clinic because he or she is itching. So we have here a question. What are the potential side effects of chloroquine? So according to CDC, chloroquine is a relatively well-tolerated medicine. The most common adverse reactions reported are nausea, vomiting, headache, and stomach pain. So these side effects can often be lessened by taking chloroquine with food. And chloroquine may also cause itching in some people. Mulagi sa akong ging kaganina. So all medicines may have some side effects. Minor side effects such as nausea, occasional vomiting, or diarrhea usually do not require stopping the antimalarial drug. So if the patient cannot tolerate the given antimalarial drug, the patient should seek for a healthcare provider so that other antimalarial drug would be recommended. So we have here a question. In what parts of the world can chloroquine be used for prevention of malaria in travelers? So we have here a map that shows an approximation of the parts of the world where malaria transmission occurs. And we have three indications. Red being malaria transmission occurs throughout, meaning na nadyo'y mahitabo nga malaria transmission sa tibok nilang nasod or like sa tibok nilang area. So the yellow indicates that malaria transmission occurs in some parts. Nakita nato diri nga ang Philippines is na-cover siya sa yellow. So ibig sabihin sa atong bansa is kanang magkada jud malaria transmission pero kanang some parts of the country only. So, green indicates that malaria transmission is not known to occur. So, we can see that ang tibok na Australia, kanang ang kadakan sa North America, o ang Europe, o ang Asia. So, moving forward sa paracetamol for ear pain and for high fever, which ranges from 38.5 degrees Celsius and above. Paracetamol lowers a fever and reduces pain. If a child has a high fever, give 1 dose of paracetamol in clinic. If the child has ear pain, give the mother enough paracetamol for 1 day. That is 4 doses. Tell her to give 1 dose every 6 hours or until the ear pain is gone. So we have here the chart. It indicates that give paracetamol every 6 hours until high fever or ear pain is gone. So age or weight is indicated as well as the number of tablets to be given sa patient. So 2 months up to 3 years nga mga children would be sa 100 mg na klase nga tablet, usa ka tablet na tibok ang ihatag, while if ang klase gani sa tablet is 500 mg is 1/4 lang siya, so tungaan na nimo siya. Ang sa 3 years up to 5 years nga children would be if 100 mg nga tablet siya na klase is 1 1/2, if ang 500 mg is kanang tunga lang siya sa tablet. So moving on to vitamin A. Vitamin A is given to a child with measles or severe malnutrition. Vitamin A helps resist the measles virus infection in the eye as well as in the layer of cells that lines the gut, lung, mouth, and throat. It may also help the immune system to prevent other infections. Corneal clouding is a sign of vitamin A deficiency which can progress to blindness if vitamin A is not given. So, vitamin A is available in capsule and syrup form. So, use the child's age to determine the dose when administering the vitamin A. Give 2 doses Give the first dose to the child in the clinic and give the second dose to the mother to give her child the next day at home. If the vitamin A in your clinic is in capsule form, make sure the child swallows it whole. If the child is not able to swallow a whole capsule or needs only part of the capsule, open the capsule, tear off or cut across the nipple with a clean tool. If the vitamin A capsule does not have a nipple, pierce the capsule with a needle. So, have you noticed sa inyong barangay na ay mag-survey or magbalay-balay nga mga BHW, tas mangutana if naba mo'y kauban nga bata sa balay or may baby, tapos na sila ihatag nga murag red nga medisina, tas mura siya rubbery, ang lubot is round, may pagka-round, tapos ang igbaw is may pagkatalinis, so mo na siya ang vitamin A. So, it is important to record the date each time you give vitamin A to a child because if you give repeated doses of vitamin A in a short period of time, there is danger of an overdose. Tapos, if high intake kasi sa vitamin A is harmful, tapos it can cause dizziness, nausea, headaches, coma, and worse, death. Okay, so we have here the chart in giving the vitamin A and mebendazole in a clinic. So first, it is indicated here that you need to explain to the mother why the drug is given, determine the dose appropriate for the child's weight or age, and then measure the dose accurately. For vitamin A supplementation, first you have to give first dose anytime after 6 months of age to all children. And then after that, vitamin A is given every 6 months to all children. So, sa treatment, give an extra dose of vitamin A, same dose as for supplementation. For treatment, if the child has measles or persistent diarrhea. So, if the child has had a dose of vitamin A within the past month or is on RUTF for treatment of severe acute malnutrition, do not give vitamin A. And then, always record the dose of vitamin A given on the child's card. So, it is also indicated here the age and the vitamin A doses. For 6 up to 12 months of na mga bata is 100,000 international unit of vitamin A dose. And for children who are 1 year and older is 200,000 international unit of vitamin A dose. So, moving on to iron. A child with some palmar pallor, which is the skin of the child's palm is pale, may have anemia, which is a condition in which a person lacks enough healthy red blood cells that carries adequate oxygen to the body's tissues. So, a child with anemia needs iron. So, give syrup to the child under 12 months of age. If the child is 12 months or older, give iron tablets. Give the mother enough iron for 14 days and tell her to give her child 1 dose daily for the next 14 days. Ask her to return for more iron in 14 days. Also, tell her that the iron may make the child's stool black and tell the mother to keep the iron out of reach of the child because overdosing of iron can be fatal or can make the child very ill. If a child with some pallor is receiving the anti-malarial drug, the sulfadoxine pyrimethamine, do not give iron folate tablets until a follow-up visit in 2 weeks. So, the iron folate may interfere with the action of the sulfadoxine pyrimethamine that contains antifolate drugs. So, if the iron syrup at your clinic does not contain folate, you can give the child iron syrup with sulfadoxine pyrimethamine. So, in addition to that, taking too much iron or overdosing of iron can cause nausea, stomach pain, vomiting, and it could also escalate into a severe case which can lead to organ failure, seizure, coma, internal bleeding, and worse, death. So we have here the chart for giving the iron. So the nurse should teach the mother to give oral drugs at home and follow the instructions below for every oral drug to be given at home. Also, follow the instructions listed with each drug's dosage table. So the age or weight of the children are indicated here, as well as the dosage for the iron folate tablets and the iron syrup. So, an important note, children with severe acute malnutrition who are receiving ready-to-use therapeutic food or the RUTF should not be given iron. So, the last topic for the appropriate oral drugs is mebendazole. If hookworm or whipworm is a problem in your area, an anemic child who is 2 years of age or older needs mebendazole. Mebendazole treats hookworm and whipworm infections because mebendazole is a type of anthelmintic drug which are used to treat infections that is caused by parasitic worms. And these infections contribute to anemia because of iron loss through intestinal bleeding. So give 500 mg mebendazole as a single dose in the clinic and give either one 500 mg tablet or 5 100 mg tablets. So we have here the chart and the indications when giving mebendazole. So first, you have to explain to the mother why the drug is given, and then second, determine the dose appropriate for the child's weight or age, and third, measure the dose accurately. So give 500 mg mebendazole as a single dose in clinic if hookworm or whipworm are a problem in children in your area, and the child is 1 year of age or older, and the child has not had a dose in the previous 6 months. So that is all for the appropriate oral drugs. Thank you.
Treating the local infections of a young infant. So most infections in newborns are caused by bacteria, while some are caused by viruses. Symptoms of infection include temperature above 38 degrees Celsius, poor breathing, poor feeding, irritability, excessive sleepiness, rapid breathing, and change in behavior. If your newborn babies have weak immune system, this is one reason why breastfeeding is so important. It provides the newborn baby with antibodies to help fight infection. As a result, breastfeed infants have fewer infections than babies who are bottled fed. When a newborn baby does develop an infection, it can become a great cause for concern. This is because newborn babies can get sick very fast. Luckily, they also respond very quickly to treatment. Most infections in newborn babies are caused by bacteria and some by viruses. A mother's birth canal contains bacteria, especially if they have an active infection. During childbirth, the baby can swallow or breathe in the fluid in the birth canal, and bacteria or viruses can get into their lungs and blood. There are a number of bacteria and viruses that can be transmitted from mother to newborn baby during pregnancy or childbirth. Occasionally, a newborn baby catches an infection after birth from someone who has a cold or flu. There are symptoms in infection of the young infant: poor feeding and difficulty, weakening to feed, excessive sleepiness, irritability, change in behavior, difficulty in breathing, pale or greenish skin, and high body temperature above 38 degrees Celsius. A number of tests can be used to diagnose the infection. However, test results usually take 2 to 3 days to come back. So, in the meantime, the doctor will prescribe antibiotics for your newborn baby while they are waiting for the test results to confirm the diagnosis. The following tests may be needed to diagnose infection in newborn babies: complete blood count, the blood culture. The complete blood count, this is when sample of your newborn baby's blood is taken. While the blood culture, the blood will determine if any bacteria can be grown in the blood. Next is the urine test, the eye or skin swab, chest x-ray, and spinal tap. So the rationale for this is if your newborn baby has an infection, they may be taken to the special care nursery of the hospital where there will be a place on a warming bed or in a incubator to regulate their body temperature.
Antibiotics are not effective in treating most diarrhea. They rarely help and make some children sicker. Unnecessary use of antibiotics may increase the resistance of some pathogens. In addition, antibiotics are costly. Money is often wasted on ineffective treatment. Therefore, do not give antibiotics routinely. Only give antibiotics to diarrhea cases with severe dehydration, with cholera in the area, and to cases with dysentery.
Extra fluid for diarrhea and continued feeding. In Chapter 8, we learned to assess a child with diarrhea, to classify dehydration, and to select one of the following treatment plans: Plan A, treat diarrhea at home. Plan B, treat some dehydration with ORS. Plan C, treat severe dehydration quickly. Each plan provides fluid to replace water and salts lost in diarrhea. An excellent way to both rehydrate and prevent dehydration in a child is to give him or her solution made with oral rehydration salt or ORS. IV fluid should be used only in cases of severe dehydration. Antibiotics are not effective in treating most diarrhea. They rarely help and make some children sicker. Unnecessary use of antibiotics may increase the resistance of some pathogens. In addition, antibiotics are costly. Money is often wasted on severe and ineffective treatment. Therefore, do not give antibiotics routinely. Only give antibiotics to diarrhea cases with severe dehydration, with cholera in the area, and to cases with dysentery. Plan A. Treat diarrhea at home. Treat a child who has diarrhea and no dehydration with Plan A. The three rules of home treatment are: first, give extra fluid, as much as the child will take. Second, continue feeding. And third, when to return. Rule number 1. Give extra fluid. Tell the mother or caretaker, give as much fluid as the child will take. The purpose of giving extra fluid is to replace the fluid lost in diarrhea and thus to prevent dehydration. If a child is not exclusively breastfeed, give one or more of the following: ORS solution, food-based fluids, and clean water. Plan A lists two situations in which the mother should give ORS solution at home. First, the child has been treated on Plan B or C during this visit. In other words, the child has just been rehydrated. For this child, drinking ORS solution will help keep the dehydration from coming back. Second, the child cannot return to a clinic if the diarrhea gets worse. Teach the mother or caretaker how to mix and give ORS. Give 2 packets of ORS to use at home. The steps for making ORS solution are presented below. Show the mother or caretaker how much fluid to give in addition to the usual fluid intake. Up to 2 years, 50 to 100 ml after each loose stool. 2 years or more, 100 to 200 ml after each loose stool. Give frequent small sips from a cup or spoon. Use a spoon to give fluid to a young child. If the child vomits, wait 10 minutes before giving more fluid. Then resume giving the fluid but more slowly. Continue giving extra fluid until the diarrhea stops. Rule number 2. Continue feeding. If a child is classified with persistent diarrhea, teach the mother some special feeding recommendations. Rule number 3. When to return. Tell the mother of any sick child that the signs to return are not able to drink or breastfeed, becomes sicker, develops a fever, blood in stool, and drinking poorly.
Why is immunizing children important? Several diseases that affect children are vaccine preventable. Given this, immunization is the single most cost-effective strategy to decrease childhood morbidity and mortality. The objective of immunization programs is to reduce and control the illness, death, and disability caused by vaccine preventive diseases. So, generally speaking, getting immunized is important for at least 2 reasons. First is to protect yourself, and second is to protect those people around you. Without the protection from immunization, these diseases could be imported and could quickly spread through the population. Why should you check children for immunizations? Ideally, every child must complete vaccination before celebrating his or her first birthday. Therefore, you must assess every child at the healthcare facility. You need to check whether they have been vaccinated for the appropriate schedule or not. You should give them a missed vaccination on the day you visit. The recommended vaccine should be given when the child reaches the appropriate age of each dose. If vaccination is administered too early, protection may not be adequate. If there is any delay in giving the appropriate vaccine, this will increase the risk of child developing the disease.
What disease do immunization protect children from? Currently, immunization programs deliver 12 vaccine antigens to protect children against the following serious illnesses: tuberculosis, poliomyelitis, diphtheria, pertussis, tetanus, Haemophilus influenza B infections, hepatitis B, and measles. Here are the additional vaccinations to protect against pneumococcal infections, rotavirus diarrhea, and HPV infections. Preparing and giving immunizations. If a child is well enough to go home, give him any immunizations he needs before he leaves the clinic. Second, use a sterilized needle and a sterilized syringe for each injection. This prevents transmission of HIV and hepatitis B virus. Third, if only one child at the clinic needs an immunization, open a vial of vaccine and give him the needed immunization. Third, discard open vials of BCG and measles vaccine at the end of each immunization session. But you may keep open vials of OPV and DPT vaccines if, first, they are fitted with rubber stoppers; second, the expiry date has not been passed; third, and the vaccines are clearly labeled and stored under proper cold chain conditions, because the OPV and DPT vials may be used in later immunization sessions until the vial is empty. Fourth, do not give OPV 0 to an infant who is more than 14 days old. Fifth, record all immunizations on the child's immunization card. Like, you will record the date you give each dose. Also, keep a record of the child immunizations in the immunization register or the child's chart, depending on what you use at your clinic. Lastly, if a child has diarrhea and needs OPV, give it to the child. Do not record the dose on the immunization record. Tell the mother to return in 4 weeks for an extra dose of OPV. When the child returns for the repeat dose, consider it to be the one that was due at the time of the diarrhea. Record the date when the repeat dose is given on the immunization card and in your clinic immunization register. And now, what are the things that you need to tell the mother or the caretaker? So, the first thing that you need to tell the mother or the caretaker is to tell them which immunization her child will receive today. The second thing that you need to do is to tell the mother about the possible side effects. So, there are 4 side effects from each vaccine. First is the BCG. BCG is a small red tender swelling, then an ulcer. Appears at the place of the immunization after about 2 weeks. The ulcer heals by itself and leaves a small scar. So tell the mother a small ulcer will occur and leave the ulcer uncovered. If necessary, cover it with a dry dressing only. So second is the OPV. OPV means no side effects. And the DPT, third is the DPT, which is the fever, irritability, and soreness are possible side effects of DPT. They are usually not serious and need no special treatment. Fever means that the vaccine is working. So tell the mother that if the child feels very hot or is in pain, she should give paracetamol. She should not wrap the child up in more clothes than usual. So fourth and last is the measles. Fever and a mild measles rash are possible side effects of the measles vaccine. A week after you give the vaccine, a child may have fever for 1 to 3 days. Fever means that the child is working. Again, so when the child have fever, it means that the vaccine is working. So there is nothing to worry, okay? So tell the mother to give paracetamol if the fever is high. And tell the mother when to bring the child back for the next immunizations. So that would be all for my report. Thank you.